Welcome to the University of Michigan Dentistry Podcast Series, promoting oral health care worldwide.
Let me define endodontics. Literally, the word means within the tooth. Actually, it is a broad specialty which deals with the biology of the pulp and the periapical tissues, but primarily is concerned with the removal of pulpal tissue from the pulp chamber and root canals when the tissue is diseased or deceased, and then filling the canals with a material which seals the space from the surrounding tissue. To do this efficiently and effectively, a knowledge of dental anatomy is of more than academic interest or an academic exercise before you go on to real dentistry. Almost all patients who come to a dental office for the relief of pain have a pulpally involved tooth. In most cases, there are two treatments for the alleviation of this pain, either extraction or endodontic treatment. Alleviation of pulpal pain is accomplished by removal of the pulp of the involved tooth. If the pulpal tissue is necrotic or dead, the pain the patient experiences is not strictly a toothache, since the pain is not in the tooth, but in the supporting tissue surrounding the tooth. The breakdown products of the dead pulp produce toxins which are irritating to the surrounding tissue and may produce an abscess, a granuloma, a radicular cyst, or a sinus tract. This illustrates a sinus tract which communicates extraorally with a pulpally involved tooth. The next slide shows the pointer communicating from the external surface on the skin to the apex of the pulpally involved tooth. Once the diseased or dead pulpal tissue is removed from the tooth, why is it necessary to fill or seal the canals? It is believed that unless this canal space is filled, tissue fluid breakdown products would continue to act as irritants to the surrounding tissue, much as the pulpal tissue breakdown products do. This slide illustrates the sealing of the canals and the healing of the periapical area. The alternative to endodontic treatment is extraction of the tooth. Loss of a tooth, however, puts an increased load on the remaining teeth and hastens their loss. Additionally, the only function of alveolar bone is to support the teeth, and when the tooth is lost, the alveolar bone atrophies or shrinks, eventually making it more difficult to support a denture when and if one becomes necessary. Endodontic treatment is also necessary to adequately restore a tooth in which so much of the coronal portion of the tooth is missing that it is necessary to make a post-preparation into the pulp chamber or root canal to gain adequate support or retention for the restoration. This represents an extreme example where the coronal portion of the tooth is missing, but in which the root is still retained in the alveolar bone. The remaining portion of the tooth, or the root, was treated endodontically. A post-preparation was made into the root and the crown portion of the tooth restored, as in this illustration. The basic principles of endodontic treatment are expressed in a so-called triad: disinfection of the canal and the pulp chamber, preparation of the canal, cleaning and shaping of the canals, and sealing of the canals. To conform with these principles, it is necessary to, 1, make an occlusal or lingual access preparation which will completely unroof the pulp chamber and provide direct access to the canal or canals and allow complete debridement of the chamber. 2, locate the canals and with the aid of root canal files, completely clean and shape the canals. It is important to remember that even so-called round canals are not really that perfectly shaped. They are very irregular, and instrumentation with the file is necessary to remove these irregularities and to shape the canal to receive the filling materials. 3, the canal is cultured. Medicaments are used to disinfect or sterilize the canal. but smoothing and shaping and irrigation of the canal is undoubtedly more effective than the medication. 4, the canals are then filled with an appropriate material. The reason for the filling material is to seal the canals from the surrounding supporting tissue of the tooth. Most root canals are filled with one or both of two basic filling materials: silver cones or gutta-percha cones in conjunction with a sealer paste or cement. The silver cone is almost pure silver. It is manufactured to conform to the size and taper of standardized files. Gutta-percha cones are also available in standardized sizes. It is a material very similar to rubber, but is harder, more brittle, and less elastic than natural rubber. Most endodontic treatment failures are due to a failure to adequately fill or seal the root canals and the pulp chamber. It is absolutely essential to gain adequate access into the pulp chamber and to the canals so that the canals can be cleaned and shaped and prepared to receive a filling material which will seal off the pulp chamber and canals from the surrounding supporting tissue. Failure to accomplish this is usually because the dentist did not consider the significance of the pulpomorphology of the tooth being treated. All studies of endodontic treatment failures agree that the mandibular anterior teeth have the highest failure rate of any group of teeth. This high failure rate is attributed to the fact that, 1, these canals are much broader in a labiolingual direction, which is not visible on a radiograph, than in a mesiodistal view, which is the view normally seen on a radiograph. And 2, that many mandibular teeth have 2 canals rather than 1 canal as commonly assumed. If the dentist is aware of this morphology, he will prepare an access cavity with minimal unnecessary loss of tooth structure to gain adequate access to the broad canal or to the 2 canals so that he may clean and shape and subsequently completely fill the canal or canals. In all instances, the pulp chamber is pretty much in the center of the crown of the tooth, and the shape of the pulp chamber conforms closely to the shape of the crown. This similarity in shape occurs because the embryonic pulpal tissue produces the specialized cells which lay down the dentin on which the enamel is subsequently deposited to form the crown of the tooth. Each tooth in the mouth has its own characteristic anatomy and its relatively common variations. The maxillary central incisor. This tooth probably has the least deviation from the average of any tooth. It almost always has a straight root. The pulp chamber is in the center of the crown and is shaped like the lingual surface. That is, it is broader at the incisal than at the cervical. The root also has an ovoid shape, being broader on the labial aspect and narrower on the palatal aspect. And the canal has the same morphology and is, of course, in the middle of the root. When preparing the canal during endodontic therapy, the file is used to convert this ovoid shape, especially in the apical third, to a round shape so that the gutta-percha cone, which is round, can be fitted into the canal. All teeth have lateral canals extending out perpendicularly from the main root canal. Most of these are located in the apical third or half of the root, but may occur as far coronally as the dentino-enamel junction at the cervix of the tooth. It does not appear necessary to fill these lateral canals. This is fortunate because it would be impossible to locate, prepare, and fill such canals. The significance to the endodontist lies in the fact that the main root canal must be sealed at the point where the lateral canal exits. Since we do not know at which point along the main canal, the lateral canal rather, is located, it becomes essential to adequately prepare and to effectively seal the main canal, at least in the apical half, and preferably to the dentino-enamel junction at the cervix of the tooth. The maxillary lateral incisor. morphologically resembles the maxillary central incisor in the shape of the root. About half of these teeth have a slight distal curvature at the apex of the root, and this can be seen on the radiograph. The pulp chamber is in the middle of the crown, and the root canal is in the middle of the root and has the same shape as the root, being larger in a labiolingual direction than in the mesiodistal diameter. The maxillary canine, like all the other maxillary anterior teeth, has a root that is broader in a labiolingual direction than in the mesiodistal direction. About 1/3 of these teeth have a distal curvature of the root. In common with all other teeth, the pulp chamber and root canal are located in the middle of the crown and the root respectively. This is usually the longest tooth in the mouth. Except for the different lengths, the access openings and the cleaning and the shaping of the canals is very similar in all maxillary anterior teeth. The length of the standard endodontic file is 25 millimeters, so that very often it is necessary to use a longer file in preparing maxillary canines. Mandibular central and lateral incisors and canine teeth are very similar, both in size and shape. This is the group of teeth with the highest failure rate in endodontic therapy. As mentioned previously, this high failure rate is due to the failure of the dentist to recognize the morphological characteristics of these teeth. The broad labiolingual diameter makes it essential to provide a lingual access opening which enables the operator to adequately clean and shape the canal. Failure to prepare and then fill the entire canal is the most frequent cause of failure in endodontic therapy. Another reason for the high failure rate is the high incidence of mandibular anterior teeth with two canals, despite the fact that most published studies of the anatomy and morphology of these teeth claim that only 2 to 4% of these teeth have two canals. A recent study done here has shown that about 40% of these teeth have two canals, which correlates more closely with what we find clinically. Knowledge of these two facts, the broad labiolingual diameter of the tooth and the presence of two canals, should significantly improve the success rate of treatment of these teeth. Maxillary first premolar teeth. About 50% of these teeth have either two canals and/or two roots. The crown of the tooth is larger in a buccolingual than in a mesiodistal direction. And the pulp chamber, therefore, is much larger buccolingually than it is mesiodistally. This means that the access opening on the occlusal surface of the tooth must conform to this shape to gain adequate access to the pulp chamber and to the canals. Even if only one canal is present, adequate access is necessary so that the broad buccolingual diameter of the canal can be cleaned and shaped and subsequently filled. Even where the two canals exit in a common foramen, it is necessary to prepare and fill both canals. Maxillary second premolars. The incidence of two canals and/or roots is considerably less frequent than in the first premolar, about 10%. About 1/3 of both the first and second premolars have a distal curvature of the roots, but this is not significant because it is readily apparent on the radiograph. It is important to keep in mind that the buccolingual diameter is much larger than the mesiodistal measurement, and that the file must be inserted to clean and shape the entire circumference of the canal without perforating the mesial or distal surfaces of the root. The apex of this tooth usually more closely approximates the floor of the maxillary sinus than any other maxillary tooth. Mandibular first and second premolar teeth. Although most older studies do not mention the incidence of two canals, a recent study done here has found that more than 12% of these teeth had two canals, and it is strongly suspected that this is a conservative figure. Clinically, we find a high percentage of mandibular premolars with two canals and two separate foramina. There are three significant features relating to the anatomy of the mandibular premolars. One, the buccolingual diameter of the canals is always larger than the mesiodistal view seen in the radiograph. Two, there is a relatively high incidence of two canals and/or roots. And three, the lingual tilt of the crown lends itself to perforation of the buccal plate at the cervical of the tooth unless the contraangle is tilted toward the buccal cusp. Maxillary first molar. There are several significant variations in the pulpal morphology of this tooth when compared to the teeth anterior to it. In all other teeth, the pulp chamber is in the center of the crown and is the shape of the crown. In this tooth, the pulp chamber is in the center of the crown, bounded by the disto-oblique ridge, and the access opening is therefore a triangle formed by the mesiobuccal, distobuccal, and mesiolingual cusps. In all other teeth, the root curvatures are mostly in a distal direction, in a plane readily visible on a radiograph. In maxillary first molars, a little more than 1/2 of the palatal or lingual roots have a buccal curvature. This is significant because it is not readily apparent on a radiograph. This curvature may be misinterpreted as an apical constriction. In about 15 to 30% of these teeth, the mesiobuccal root has two canals, and about 1/2 of these terminate in separate foramina. This extra canal has an orifice on a line from the mesiobuccal canal to the palatal or lingual canal. The mesiobuccal root is usually broader in a buccolingual direction than the distobuccal root, which is quite round, at least in the apical third. The palatal canal, on the other hand, is broader mesiodistally than buccolingually, and as a result does not lend itself as readily to single silver cone filling material. This canal is usually filled with gutta-percha cones or a combination of a silver cone augmented with accessory gutta-percha cones. The maxillary second molar is very similar to the first molar. The significant differences are: one, the second mesiobuccal canal is rarely found in the second molar, and two, the buccal curvature of the palatal root occurs with much less frequency, only about 37% of the time as opposed to 55% in the first molar. Mandibular first molar. This tooth usually has a mesial and a distal root of about equal length. The mesial root has two canals, and the distal root purportedly has a single canal. The pulp chamber is pretty much in the center of the crown and has a shape which closely conforms to the shape of the occlusal surface of the tooth. The mesial root usually curves distally, and the distal root is straight about 75% of the time. The two canals in the mesial root are usually round, and at least the apical 1/2 of the root, and therefore lend themselves readily to a single cone filling. The single canal in the distal root is usually ribbon-shaped, being broader in a buccolingual direction, and therefore does not lend itself to a single silver cone root canal filling. The most significant difference or deviation in mandibular first molars is the high incidence, as shown in several recent studies, of the presence of two canals in the distal root. It is estimated that almost 1/2 of mandibular first molars have two distinct canals in the distal root. The presence of two canals may be suspected in the radiographic view by the direction of the distal canal when a file is inserted, or by the size of the canal. A single canal is much broader or ribbon-shaped than when the distal root has two canals. The second molar closely resembles that of the first molar in morphology, except that the incidence of two canals in the distal root is almost negligible. It is important to realize that on a radiograph, an area of bone destruction may be quite large before it is visible. This is due to the heavy cortical plate, which may mask the absence of a more radiolucent cancellous bone. Carefully controlled radiographic studies have shown that, at least in the mandibular molar area, almost all of the cancellous bone can be removed without producing any change in the density of the radiograph. This shows a section of the right mandible with the buccal cortical plate removed. The next slide is a radiograph of that area. Subsequently, more of the cancellous bone was removed. In this picture, some of the cancellous bone was removed, exposing more of the apex of the mesial root, and about in the middle of the picture you can see the tip of the distal root has been completely exposed. With the removal of all of the bone, there is barely a noticeable change in the radiograph of this area. Only after all of the bone was removed from the apex of the mesial root and a perforation made of the lingual plate at the apex of the distal root was any of this bone removal evident on the radiograph. In summary, each tooth can have considerable variation from the average in length, curvature, size of canal, and number of canals and roots. It is important to recognize the width of the root because in many instances the larger diameter of a root canal may exceed the smaller diameter of the root. For example, the labiolingual measurement of a root canal of a mandibular incisor may be larger than the mesiodistal measurement of the root, and an attempt to convert this canal to a perfectly round shape by filing would result in mesial and/or distal perforation of the root surface. The canal can be prepared more adequately by recognizing the morphology and preparing an access cavity which enables the operator to hone or shape the entire root canal surface without destroying the integrity of the root. This same principle is true in every tooth, and knowledge of the pulpal morphology will greatly enhance the success of your treatment.
You've been listening to a presentation from the University of Michigan School of Dentistry, which is dedicated to supporting open learning and open educational resources. This recording is licensed under the Creative Commons. It may be reused and redistributed for nonprofit use. Please attribute materials to the University of Michigan School of Dentistry and redistribute under this same license. For more information on how this and other University of Michigan School of Dentistry recordings may be used, visit www.dent.umich.edu/license.